Okay. So my name is Natasha Garg. I am a medical oncologist from the City of Hope in Upland, and today I will be discussing several topics on breast cancer. So these are some objectives that I plan to be covering today. I will be talking a bit about risk factors of breast cancer, screening modalities for diagnosis of breast cancer, treatment, newer therapies on the treatment of breast cancer, as well as new and upcoming innovations in breast cancer treatment. Okay, so the female breast is made up of three specific types of glands. One is the lobules, which are glands that produce milk. And then the other thing are ducts, which are tubes that carry the milk from the lobules to the nipple. And then thirdly, stroma, which is fatty or connective tissue that surround the ducts, the lobes and lobules, and the blood vessels. So on the right side, you can see a picture of these three structures. So here are some of the common signs that a patient can experience of breast cancer. More commonly, we do tend to present with lump. Other things that you may experience is nipple discharge, skin dimpling, any type of breast or nipple pain, sometimes nipple retraction or inversion, redness or erythema around the skin, changes to the skin texture around the breast, any type of lymph node changes such as swelling, both of the breast as well as underneath the armpit. So how common is breast cancer? It is the most common cancer in women in the USA and the second leading cause of cancer-related death in women in the US. As of January 2019, there was a reported of a little over 3 million women with a history of breast cancer in the US. About 1 in 8 or 12% of US women will be diagnosed with breast cancer in their lifetime. And estimated new cases of invasive breast cancer in 2019 was about 268,000. Now, the total death rates are decreasing, however, since 1989, and there has been about a total 40% decline since 1989 through 2017. And I believe a lot of that is related to improvement in detection, treatment, as well as increased awareness. So most causes of breast cancer, like most cancers in general, are unknown etiology. However, some of the theories say that it's most likely due to mutations in DNA or genetic materials of cells to the genes responsible for regulating growth of our cells and keeping them healthy. So these changes could be either due to age, lifestyle, or other type of factors such as environmental factors. So what are some of the risk factors for breast cancer? One is female gender. Second is age. So our risk of breast cancer increases as a woman gets older. Third, genetic, which are inherited changes specifically in BRCA1 or BRCA2 genes and in other genes that increase the risk of breast cancer. Family history, patients with a higher family history. So for instance, a member of the family with breast cancer in the first degree relative have a higher risk of developing breast cancer, and a personal history of breast cancer as well. Another risk factor is postmenopausal women taking hormonal therapy. So taking hormones that contain estrogen and combined with progestin or estrogen alone supplementations increase the risk as well for breast cancer. Radiation treatment, especially patients who've received radiation to the breast or chest wall. Patients who also have dense breast tissue detected on mammography. Patients who have a first childbirth at an older age or never having given birth because there's more estrogen. Patients who have more menstrual cycles and again starting menstruation early or having menopause later in life. Obesity is a risk factor as well for breast cancer because fat tissue is the body's main source of estrogen after a woman has completed menopause. And then alcohol use also is a risk factor for breast cancer. So some lifestyle modifications that patients can do on a day-to-day basis to minimize their risk of breast cancer. These guidelines are put out by American Cancer Society. Number one is to achieve and maintain a healthy weight. To be physically active, they recommend at least 150 minutes a week of moderate aerobic activity. Definitely starting to screen at an age of 40, at least 40 and earlier if you have a high risk family history, which I'll be talking about. Limiting alcohol to 1 drink a day for women, abstinence from smoking, and minimizing the use of hormonal therapy for menopausal symptoms if that's possible. And then in terms of diet, there's no specific food or diet that can prevent you from getting breast cancer or any cancer in general, but you can fuel your body with the healthiest. It can be to boost your immune system. So usually that consists of low-fat diet, no more than 30 grams of fat a day. American Cancer Society also recommends eating 5 cups a day of vegetable and fruit, incorporating that into your diet, limiting saturated fat intake to less than 10% of your total calories on a daily basis, incorporating foods that are high in omega-3 fatty acids, and avoiding trans fats, processed meats, and smoked foods. Okay. So 85% of women who get breast cancer surprisingly do not have a family member that's been diagnosed with it. Actually, only about 5 to 10% are hereditary gene mutations, which means that these are genes that are passed on from parent to child. Here are a list of some of the genes that we see that increase the risk of breast cancer. More common ones are BRCA1 and BRCA2. These specific genes, BRCA1, BRCA2, also increase your risk for breast and ovarian cancers, as well as other types of cancers too. So it's very important to discuss screening timing, intervals, and risk reduction strategies with your oncologist, as patients who do have hereditary breast cancers should be screened differently. So who should undergo screening? There's several guidelines out there, but and they differ with every organization. But in general, most oncologists start with screening at age 40 to 50 and having an annual mammography. And then, of course, women that are at high risk. So I just had mentioned hereditary breast cancer, but patients who have personal or family history of breast or ovarian cancers with known pathogenic mutations. And then, of course, women who've had prior chest radiation should also definitely get screening, some of them earlier than age 40. Okay. So the major modality of screening is mammogram. Mammogram basically allows for early detection but does not prevent breast cancer. Basically uses an X-ray image to get a picture of the breast. The breast is basically pressed between 2 plates so that we can obtain these images. So there's 3 basic types of mammography. Number 1 is screen film, which again uses the X-ray to record images. Number 2 is digital, which uses a lower dose of radiation. And then 3, which is an upcoming modality, which is a 3D mammograms, which uses multiple X-rays to create a 3D image. And this way, this increases breast cancer detection compared to digital. So it does reduce the overall recall rate. There's no data on this specifically for survival benefit, but most organizations are choosing 3D mammography over the standard 2D mammography. So after you have a mammography, the radiologist will usually put it into a category of 0 to 6. This is called the BI-RADS system, and this is how they report the findings. So basically category 1 would mean that it's a negative scan, and category 2 would mean that it's a benign finding. And then you can kind of see from 3 to 6 as well, whether or not they recommend doing a biopsy or not. So other imaging modalities that we use to monitor the breast are ultrasound and MRI. Now, these are not standard of care in terms of screening, but they may be used as adjuncts for additional testing. So basically, a breast ultrasound is a non-invasive test that uses sound waves to create images of the breast. Again, not typically used for routine screening. However, it is used very commonly as a follow-up test after an abnormal finding on a mammogram. And then a breast MRI uses magnetic fields to create the image of the breast. And sometimes we use this in screening in women that are at higher risk. But again, this is usually used as an adjunct to an MRI or even ultrasound. So if there is a suspicious lesion on imaging modality, then the next step usually we do is to perform a biopsy. Once a biopsy is completed, these are the information that we typically see on a biopsy report. So we do see many forms of information there, but I highlighted the most important, which are, of course, the final diagnosis, whether or not this is an invasive or a non-invasive type of tumor, hormone receptor status, so whether or not they're estrogen receptor or not, HER2 status, as well as whether or not lymph nodes are involved. Okay, so the three more common types of breast cancer that we see are ductal carcinoma, which means that the cancer cells have originated from the ducts of the breast, inflammatory breast cancer, which means that it has involved the overlying skin, or lobular carcinoma, which means that the cells have originated from the lobes or lobules of the breast. So this is a picture of what ductal carcinoma in situ and lobular carcinoma in situ represent. Basically, in situ means that it really hasn't spread outside where it originated from. So for instance, for ductal carcinoma, it hasn't spread outside the duct, and you can see that on the picture comparing the normal duct and DCIS. So the abnormal cells are contained. Usually these types are an early stage of breast cancer. Sometimes they're referred to as precancerous lesions. And then on the top right, I had mentioned inflammatory breast cancer as a type of breast cancer. This is usually what we tend to see. A lot of times the skin is involved, so we may see like skin dimpling, inversion of the nipple, as well as red or swollen breast. So another key point to pick up from the biopsy report is whether or not cancer cells express hormone receptors. So hormone receptors are proteins that are found on some cancer cells when hormones, so such as estrogen or progesterone, attach to these receptors that causes the cancer cells to grow. So when we say hormone receptor negative, that means that the breast cancer cells do not express any of these receptors on the surface. When they're positive, we tend to say that these breast cancer cells do express receptors. So we tend to call them estrogen receptor positive or ER positive, or progesterone receptor positive or PR positive. So this is important as this guides treatment or not. Patients who are hormone receptor positive would benefit and respond to anti-hormonal therapy, versus patients who are hormone receptor negative. We don't tend to use these types of agents. Another piece of information that'll be provided on the biopsy report is the HER2 status. So similar to hormone receptor, HER2 is also a protein that tends to appear on the surface of some breast cancer cells. You may have it seen as HER2 neu or ERB2 as well, but they're all part of the same family. So HER2 protein is an important part of a pathway for cell survival and growth. So patients who are HER2 negative do not have expression of HER2 protein, or they have very minimal expression. And then HER2 positive, you can see on the picture on the right side, will have an excess amount of HER2 receptor. So similarly to hormone receptor positivity, if a patient does express HER2 receptors on their cell surface, this will be important in terms of determining what treatment to use for therapy. So this pie chart just gives a breakdown so you can kind of see hormone receptor positive breast cancer tends to be the most common by more than 50%. Next would be HER2 positive, and thirdly, triple negative, which means that they do not express any of the receptors. Okay, so now I'm going to switch gears and talk a little bit about treatment for breast cancer. So I put this slide here, this flow chart here, just to show that the treatment of breast cancer is overall very complex and dynamic, and it is changing almost on a day-to-day basis, at least for medical oncology. So these treatment pathways are very unique and variable. They're very highly individualized depending on the patient and their pathology. So it really does require multidisciplinary planning with your medical oncologist, surgical oncologist, and radiation oncologist. So there's two overall treatment goals you can think of when we're treating breast cancer. The first is to get rid of the cancer itself. So a lot of times either that requires surgery up front or requiring either hormone or chemotherapy before the surgery to shrink the tumor. And then secondly, to decrease the risk of the cancer coming back, right? So the three common modalities that we use for treatment are surgery, radiation to the breast and chest wall, and systemic therapy, which includes chemotherapy, hormonal therapy. And then whether not all cancers require treatment with all three of these, again, this is a very highly individualized decision that's made by the patient's medical team. So treatment pathways are again, unique and variable, but I will be talking about the basic treatment that we do for all three of these. So one type of surgery that's offered to certain patients is a lumpectomy, or another word, partial mastectomy. So what this is that the surgeon removes the tumor as well as some of the normal tissue that surrounds it. And the goal is to achieve negative margins, which means that the tumor has been completely removed. A lot of times patients will require radiation therapy after. And again, this is only offered to a certain amount of patients. And of course, most of these are early stage breast cancer patients or a smaller tumor size. So another surgery that's offered is a total or simple mastectomy, which means removing the breast, and the tumor, which is included, as well as some lymph nodes. And thirdly, a type of surgery that's offered is called a modified radical mastectomy, which includes taking out the breast and tumor, lymph nodes, but they may also require taking out some of the chest wall muscle as well. So after surgery is complete, we would usually get another pathology report. And with that, we're able to determine something called pathologic staging. So with this, it kind of describes the extent of cancer that's within the breast itself. And this is important because it does help plan treatment. So the breast cancer staging, specifically pathologic staging, is a very important factor for prognostic scoring in general. So of course, the earlier the stage, the better the prognosis will be. So when we do pathologic staging, we usually use the widely used T and M stage. T stands for tumor size, N stands for the number of lymph nodes that are involved with cancer, and then M stands for metastasis, so whether or not the cancer is spread to other areas of the body. So here's a breakdown of staging for breast cancer currently. Our staging is much more complex, and there's multiple subtleties that are changing very often. But in general, we can kind of think of breast cancer staging from 0 to 4. So 0 would be, again, the in situ types of breast cancer that have not spread to any nearby tissues. Number 1, or stage 1 would be early stage cancers that have spread to tissues in small areas. Stage 2 would be more localized. Stage 3 we would call regional, that have spread with more lymph nodes involved. And then stage 4 would be distant metastasis. So usually we do not do any additional staging scans, meaning like CT or MRI or PET scan, if patients are clinically stage 1 or 2. Um, if there are signs or symptoms that the patient presents with, then of course that would guide us to certain types of scans. So for instance, if a patient has bone pains, then we may be prompted to order a bone scan. And then for patients who present with clinical stage 3, then we would routinely order at least a CT, chest, abdomen, pelvis, and a bone scan. Okay, and I'm going to talk a little bit about systemic therapy, which is my role as a medical oncologist. So with systemic therapy for breast cancer, this includes chemotherapy, hormonal therapy, targeted drugs, and or immunotherapy. So there's many ways that systemic therapies can be offered or administered. Most commonly, they're intravenously. Sometimes we can offer certain types of systemic therapies, either oral or injection. So with chemotherapy, we either give chemotherapy before surgery or after breast surgery. So if we do it before, we usually call that neoadjuvant chemotherapy, and we tend to use this in women who present with larger tumors. So the goal of neoadjuvant chemotherapy is to shrink the tumor and the lymph nodes, if involved, to make the surgery easier to remove maximal amount of tumor. Now, if we give chemotherapy after surgery, then we call this adjuvant. And the goal for this is to reduce the risk of the breast cancer recurring or metastasizing or traveling. So very commonly, medical oncologists tend to get a certain type of recurrence score called the Oncotype DX. What this does is it helps with certain types of patients with hormone receptor positive, lymph node negative, or 1 to 3 lymph nodes involved. It helps determine whether or not the patient would benefit from chemotherapy in addition to hormonal therapy. And usually on the right side, I put a sample of what the report looks like. It will come up with a score as well as what is their risk for recurrence in 9 years and whether or not the patient would benefit from chemotherapy. So again, this report is not for all women. This is only used in select women. And what guides us is usually whether or not they're hormone receptor positive and if they have lymph node involvement. So how do we choose the chemotherapy regimen? So each person's treatment plan will be very unique because everybody's tumor biology is different, right? So usually a patient may receive one drug at a time or a combination of different drugs given at the same time, right? So for the most part, chemotherapy regimens last about 3 to 6 months. And some of the characteristics that we look at into choosing a chemotherapy regimen is, of course, staging, whether or not they express the hormonal receptors or HER2 receptors like we talked about, whether or not a patient has received previous treatments, their overall health condition, of course, patient's preference, age, and very importantly, side effect profile of chemotherapies. We also tend to use chemotherapy highly in patients who have stage 4 or metastatic breast cancer. And this tends to be the standard of care for metastatic disease. And here our goal of therapy is, of course, to control the disease or slow the cancer growth and balance a patient's quality of life. So it's usually not curative in stage 4, and the goal is, again, more for control of disease. So the chemotherapy regimens that we use mostly in stage 4 tend to be a bit different, and they're administered one drug at a time, and this is to limit the amount of side effects experienced. So now I'll talk a little bit about the side effects to chemotherapy. There are short-term and long-term side effects to chemotherapy. Short-term, usually we see most commonly hair loss, nausea, vomiting, diarrhea or constipation, sometimes fingernail and toenail weakness, pain, mouth sores, fatigue, anemia or low red blood cell count, and leukopenia or neutropenia, which means low white blood cell count. So some long-term side effects after chemotherapy is early menopause, weight gain, fatigue, cognitive dysfunction or chemo brain, heart problems such as cardiomyopathy or congestive heart failure, and sometimes secondary malignancies such as leukemias. Okay. So now I'm going to talk a bit about hormonal therapies. Hormonal therapy is a little bit different than chemotherapy. The goal of hormonal therapy is to lower the amount of estrogen in the body. This works by blocking the action of estrogen on breast cancer cells. Now, again, hormonal therapy medications are not effective against hormone receptor negative breast cancer, and we usually use them for hormone receptor positive breast cancer. So there's two categories of hormonal therapy drugs. One of them is called a selective estrogen receptor modulator. That drug is tamoxifen. And then three other drugs are under the category of aromatase inhibitor, and those are Arimidex, Aromasin, and Femara. So estrogen in our bodies are usually created through two pathways. Number one is the ovary, which is predominant in premenopausal women. And then secondly, in the adrenal gland, which creates a precursor androgen, which is converted to estrogen. And that tends to be more so in pre and postmenopausal women. So for premenopausal women, since the majority of the estrogen is made in the ovaries, we tend to administer tamoxifen. And if we do aromatase inhibitor, we do aromatase inhibitor with ovarian suppression medication. For postmenopausal women, since we have less to no estrogen being made in the ovary, we tend to use more aromatase inhibitors. So a bit different from chemotherapy side effects. Hormonal therapy side effects include bone and joint pain, osteoporosis, high cholesterol, mood swings. With tamoxifen specifically, you can get blood clots, risk of stroke, and higher risk for endometrial or uterine cancer. Okay, so now I will just end the talk with briefly talking about novel therapies in the treatment of breast cancer. So one novel therapy that we have been incorporating is targeted drugs. So targeted therapy are drugs that attack cancer cells, but they have less harm to normal cells or normal organs. So these are target-specific characteristics of cancer cells, such as certain types of proteins that allow the cancer cells to grow rapidly. So here's a list of some targeted therapies that we use for breast cancer treatment. You may have heard of Herceptin or trastuzumab or Perjeta. There's also advent of CDK4 or 6 inhibitors, which again are targeted therapies, PARP inhibitors, as well as TDM1 medications. So I previously mentioned that hormone receptor positive breast cancer is the most common subtype of breast cancer. There has been much research going into hormone receptor positive breast cancer. So these drugs here are recently approved FDA medications that we use with hormonal therapy for advanced or metastatic breast cancer. And these medications are palbociclib or Ibrance, ribociclib or Kisqali, and abemaciclib or Verzenio. And these combinations are also being tested currently in the treatment of early stage hormone receptor breast cancer as well. We've also recently come up with a certain type of mutations that we see fairly commonly in hormone receptor metastatic breast cancer patients, which is the PI3 kinase inhibitor. So patients who do harbor this mutation, we are able to offer this as a treatment modality. So for many years, HER2 positive breast cancer was considered to be a very poor prognosis, and a lot of that was due to lack of medications. Nowadays, we do have many targeted therapies that target the HER2 receptor. So some of these are trastuzumab, Herceptin, pertuzumab, Perjeta. Kadcyla, which is FDA-approved treatment for advanced HER2-positive breast cancer. Lapatinib, which is also used for HER2-positive metastatic breast cancer, and Nerlynx. And then in the realm of triple negative breast cancer, of course, triple negative tends to be the hardest subtype to treat because they lack both hormone receptors as well as HER2 receptors. So generally, chemotherapy is the mainstay for treatment of triple negative breast cancer. So there is ongoing studies that are testing new treatments for this type of breast cancer. So some examples are, again, PARP inhibitor that we have previously discussed about. And then, of course, immunotherapy, which has shown promise in patients with triple negative disease. So immunotherapy recently gained approval for triple negative breast cancer. Immunotherapy has been used in other types of cancers, but basically what immunotherapy is it uses the power of your body's immune system to attack these cancer cells. So in March 2019, breast cancer received its first FDA approval for immunotherapy, and this was for patients with triple negative breast cancer and who had a certain type of marker called PD-L1 that was positive. And then, of course, down the road and in the pipeline for breast cancer, novel trials and drug approval, there is active research which is ongoing. City of Hope is working on CAR T-cell immunotherapy for patients with HER2-positive breast cancer, looking at certain types of blood tests that may predict whether or not a patient would relapse years later. And then, of course, there's also recent targeted therapies that are being developed. So one potential target is called the STAT3 pathway, which is a protein that's highly activated in cancer cells, specifically breast cancer cells. Then recently, there are some recent drug approvals. We talked about immunotherapy, which is being used for triple negative breast cancer, and then the PIK3CA mutation, or PIKRA, which is the name of the medication that's used currently to treat postmenopausal metastatic hormone receptor breast cancer. So there's many resources out there for patients regarding breast cancer. I put the top 3 that is very informative. The first one is the Susan G. Komen website on breast cancer. So I provided the link here, as well as NCCN, which is our National Comprehensive Cancer Network. This is geared towards patients, and American Cancer Society as well. So I just wanted to end by saying thank you to for allowing me to talk about breast cancer, a topic that I'm very passionate about, and thank you for the viewers for viewing this presentation.